Okay, we'll start the session. The presenters are Dr. Anubhav Goyal, Dr. Hasna, Dr. Ashwati, and Dr. Jyoti Anup. Okay, Dr. Anubhav Goyal.
Anubhav Goyal. No, I sent that time uploaded. Send before by mail. They have not mail only. Okay. So, tell to third speaker. You got third speaker by the time I upload the video.
Okay. So, I'll. Okay, please, Dr. Hasna here. Okay, you can present.
Good morning. Few intumescent cataracts, no financial interest. Intumescent cataracts are notorious for intraoperative complications following rhexis extension due to high intralenticular pressure, which may be caused by swollen cortical fibers or liquefied cortex. Getting a good rhexis is the key in conquering such cataracts. You have to stain the capsule well. You have to keep the stain a little extra seconds to get adequate staining of the anterior lens capsule. After putting a dispersive OVD, fill the chamber with a heavy molecular weight OVD, but don't overpressurize the chamber just before the rhexis. Start the rhexis with a small flap. As soon as the milky fluid comes out, wash it and put visco. Better to use a forceps for rhexis in order to get good control of the flap. Apply centripetal force or pull the flap centrally, and as you progress, you can enlarge the rhexis in a helical manner. You can start the rhexis with a cruciate incision also. In this case, the rhexis we started with a small flap, and as I am not able to manipulate the flap from the side port, I put the main port, and through the main port with the forceps I managed that area, and again put visco, fill the chamber, and with the forceps just trying to enlarge the rhexis and put visco again, fill the chamber with the forceps. I am trying to finish the rhexis. You can start with a cruciate central puncture, which will help in preventing the Argentinian flag sign. Now I have put that cruciate puncture and getting a small flap, and this is a mid-dilated case, and the fluid comes out, and you have to put again the visco, and the fluid escapes. Once the fluid escapes, the intralenticular pressure comes down, and now it is like any other case, and in this case it is a mid-dilated pupil, so follow the pupillary margin in order to get a decent size rhexis. And milking of the fluid pocket from periphery to center should be done. And the rhexis is completed. Another case of mid-dilated pupil with intumescent cataract. Again, in the similar way, you have to complete the rhexis. And this is a case. You can see the spockbill pattern of the swollen cortical fibers. You can see the pockets. And in such cases, also, again, you have to put a cruciate incision. You can either do a helical rhexis or a two-stage rhexis. Start with a small flap. You have to be patient to form the chamber multiple times in order to get a good control of the rhexis and a well-formed anterior chamber throughout, because at any time the flap can run off. Another option is first you get a small rexis, then putting a nick using a micro rexis forceps, you can enlarge the first rexis. So after putting a small rexis, decompress the bag well by aspirating the fluid. Then you can enlarge the rexis in the second stage. Here I am doing a helical rexis. So getting a good rexis is the key in conquering these sort of intumescent cataracts. So this is another case of hard cataract which I thought was little intumescent, but the intumescent factor was not there. In such cases, you have to aim a big rexis because this is a little hard case. So you can safely do, if there is no intumescent factor, you can safely do a big rexis so that your nuclear manipulation part will be easy. Do minimal and gentle hydro in such cases by injecting small amount of fluid at multiple sites and rotate the nucleus. Decompress the bag well. And now it's time for phaco. In the nuclear management part, what is more important is the adequate separation of the nuclear fragments. Most of these cataracts are soft, but there can be hard cataracts too. This is a little hard case, but I could manage the case. The adequate separation of the nuclear fragment is the most important thing. Energy and vacuum parameters should be set according to the nuclear hardness. This is a soft case. In soft case, the phaco part is the most easiest part. You can separate all the fragments well and be at the center always. The probe should be at the center always. The bevel of the phaco should be side base. And use your left hand for moving the pieces around the probe in order to quicken the process. And in the last piece, eating of the last piece, you have to be vigilant. In hard cases with leathery posterior plate, ensure the complete separation of the nuclear fragments by chopping till the posterior pole and ensure the separation of the last fiber in the posterior pole. Be at the center. You can use heavy molecular weight OVD and watch the PC for fluctuation, and if it is there, reduce the vacuum, come out and put visco before eating the last bit of nucleus. Cortex wash and IOL implantation done as usual, and thorough OVD removal is important in all cases, especially in cases where we have used high molecular weight OVD. Patience is in getting a good rexis and adequate separation of the nuclear fragments in the phaco part are the key in conquering such cases. Thank you.
Okay. Good video, Dr. Hasna. I have a doubt whether you are a PG or a practicing.
Practicing.
Okay, you look very young. Then what about spiraling rexis or secondary rexis? Why you are not doing that? That will be more safe, no?
Yes, ma'am. Depending on the how the nuclear hardness and how the intralenticular pressure is, depending on that I decide how to proceed. First I do a cruciate incision, then if it is the fluid cortex, it will come out and then it is easy to proceed. If it is only the swollen cortex, then I will either do a 2-stage rexis, decompress the bag, or I will do the spiral rexis.
Do you use capsule forceps?
Yes, ma'am. I am comfortable with the needle rexis, but in case that fibrosed capsule, and if in such a severely intumescent cataract, in those cases I will use forceps.
Thank you very much.
Thank you.
Next I invite Dr. Anubhav Goyal.
First video is 45 years old lady with head movement vision showing technique and importance of bimanual membrane dissection. After complete core vitrectomy, careful 360-degree posterior hyaloid truncation relieves traction on posterior PDR membranes. Complete removal of vitreous adhesions to the membranes should be confirmed. Bimanual membrane dissection with scissors and forceps under chandelier assisted illumination is mainly done for extremely adherent posterior pole membrane, which are difficult to remove with conventional instruments like vitreous cutter. In between, bleeding should be removed and bleeder should be constantly cauterized for a better visualization. After complete membrane removal, retina is flattened by fluid air exchange to the retinal brakes. Endo laser given around the brakes and 360-degree retina, and the case was closed under silicone oil implantation. Post-operative vision improved to 660 in this case. This is case of 56 years old lady with head movement vision showing technique and importance of segmentation, delamination and extreme step of retirectomy done in cases with extremely adherent peripheral retinal membranes and macular TRD. Initial step of vitrectomy should be done carefully in all PDR cases to relieve traction around the membranes, which help to prevent recurrences. Segmentation separates membrane in various islands which can be removed by cutter. This step shows dissecting membranes from the retina which can be later on removed completely. During the surgery, bleeder should be constantly cauterized and bleeding should be constantly removed to keep the clear view. This is peripheral adherent membrane which is difficult to remove with any of the instruments. Some membranes can be easily removed with forceps by pinch and peel technique. This adherent peripheral PDR membrane relieved from all vitreous attachment carefully, and then extreme step of retirectomy was done to settle the retina. In the end, fluid air exchange was done, all breaks and retina was lasered and the case was closed under silicone oil implantation. Post-operatively, vision improved to 618 N18 with OCT showing attached macula. PDR surgeries are challenging, but with advanced surgical instruments and manuals, these surgeries can be efficiently accomplished. Thank you.
Really difficult cases, and you could restore useful vision in these patients.
Yes,
It's
ma'am.
really great. Over to your next video.
Yeah.
Okay. Just
The vision that you have quoted is at which day post-operative?
Ma'am, 6 weeks. We are usually checking vision after 6 weeks only. Because it's very difficult to judge the vision improvement, good vision improvement immediately after retina surgeries. There are a lot of factors which cause vision impairment after the retina surgeries. Can be retinal edema, can be preretinal hemorrhages in all these PDR, advanced PDR cases.
So most of the cases you have injected silicone oil?
Yeah, no, not like this. Most
Require
some cases which don't have any iatrogenic breaks or not much of bleeding, no remnant membranes, or very small break superiorly, we are injecting just gas or just leaving under saline also.
okay, thank you.
My Savior, the retention sutures. We had a 48-year-old female who was status post scleral tear repair. She had aphakia, aniridia, vitreous hemorrhage, and a long-standing retinal detachment. Vision was hand movements. 325 gauge sclerotomies were made. Limbal markings were then made at the desired points for retention sutures. Anterior chamber membranectomy was performed using a vitrectomy cutter. Limbal grooves were then created to bury the suture knots. 9-0 proline suture with a straight needle was passed vertically across the anterior chamber from one side and removed from the other side with the assistance of a bore of a 26 case needle. The suture was then passed back to the other side at a distance of about 2 mm from the previous exit. Both loose ends were then tied and the knots were buried in the groove. The procedure was repeated in the other half of the anterior chamber vertically as well as in both halves horizontally in the same plane. The end result was a double hash-like configuration of sutures across the anterior chamber. Core vitrectomy was started. Proliferative vitreoretinopathy membranes can be seen due to the long-standing retinal detachment. The proliferative membranes were peeled using a diamond-dusted forceps, and the retinal folds were opened. Subretinal bands were removed from a iatrogenic break. Breaks were marked with endocautery. Inferior nasal retinotomy was created to drain the subretinal fluid. Also, a relaxing retinotomy was created in the inferior retina. Fluid air exchange was performed. Endolaser was given to the peripheral retina and around the areas of breaks and retinotomies. $5,070 of silicone oil was injected to a level just at the plane of the retention sutures. Oil overfill was avoided. The anterior segment photo taken on post-op day 1 showed no silicone oil corneal touch. The retina was on post-operatively, as can be seen in this post-op ophthalmos picture. Vision had improved to finger counting 1 meter. This silicone oil retention sutures saved my day.
Okay. So you made a mesh over that area?
Yes, ma'am, I made a mesh. Patient was having
For what?
NID.
For what?
There was no iris, only one eye of the patient, otherwise other eye was blind. This was the eye post-trauma with very poor vision. So I thought I should do something to give some vision, some ambulatory vision, so the patient can live her life. She was 60 years old lady.
So instead of iris, you are using that mesh?
Ma'am,
Or
there
you are
was
placing an IOL over that?
long-standing retinal detachment with PVR. It was very difficult to put an NIRD IOL in a patient in whom you have to do a lot of retinal maneuvers. You need a good visualization for do posterior maneuvers also. So if you do put a iris or whatever artificial measure, it will have a small pupillary area, and to that pupillary area, it's difficult to do retinal maneuvers, especially in periphery.
So the purpose of that sutures placed is to place the IOL?
To prevent oil migration in the AC, to prevent corneal degeneration.
But oil will come later, no?
No,
After
ma'am.
emulsification?
This mesh will, this I have put 5,000 centistrokes. 5,000 centistrokes are the quality, it will not emulsify faster. Patient have now nearly 1.5 years follow-up. He is still maintaining 3 meters vision, coming to OPD walking. 5,000 will not emulsify faster. And if it fast emulsifies, if you cease emulsifying oil, it will usually emulsify, and emulsification bubbles will be more seen earlier in the post retina. It will not collect in the AC so fast. This mesh will act as a what we call it, tension impediment to prevent migration of oil. Will make
just a mesh, no? There are, so
it's an old technique, ma'am. Since 1960 it has been described. It's not a new technique, but not been frequently used because We have NREDA, SFILs for doing the surgeries, but in those cases, we don't have RDs or these complicated posterior segment problems. If in this case I would have implanted an NREDA SFIL, I would have found a lot of difficulty in doing retina surgery.
Okay.
Yeah, thank you.
Okay, thank you.
Thank you, ma'am.
Next, Dr. Ashwati. Okay.
Tips to tackle traumatic subluxated lens. This is a case of 42-year-old male with defective vision right eye following blunt trauma. On examination, infratemporal zonulodialysis of 4 blockers and cataract noted. We plan for phacoemulsification with capsulotension ring with intraocular lens implantation under guarded visual prognosis. We can see an FAK crescent on retroillumination. Side port is created. Under air bubble injection, trypan blue staining is done and washed. Viscoelastic is injected. It is advisable to use cohesive high molecular weight viscoelastics as it acts as a tamponade and prevents the prolapse of the vitreous through the area of the zonulodialysis. By using 2.8 mm keratome, a clear corneal incision is made. Capsulorhexis is one of the most difficult part in such cases due to lack of resistance from the zonules. Start the capsulorhexis away from the subluxated area to avoid the zonular stress. We can see the difficulty in making a rhexis, the difficulty in taking the flap and dragging the flap. Aim for slightly smaller rhexis in case we want to do an optic capture. A gentle hydrodissection is done to separate the epinucleus. Avoid the nuclear rotation, which further weakens the zonules. Phacoemulsification is done in stop and chop technique. Phacotranche is initiated to get a linear groove, and after reaching the adequate depth, the nucleus is split into 2 heminuclei using the phacoprobe and the dialer. Now we notice the prolapse of the vitreous into the anterior chamber and peaking of the pupil. So phacoemulsification is stopped and the 23 gauge trocar is inserted 3 mm away from the limbus. Tricot is used to stain the vitreous into the anterior chamber and anteriorly prolapsed vitreous is cut with the vitrector. Now we can go again in phaco 2 mode, bringing the nuclear fragment into the pupillary plane and emulsify. Here the phaco is done with low parameters, which prevents the raised intraocular pressure and less zonular stress and dialysis. Bimanual irrigation and aspiration is done starting from the side opposite to the area of the zonulodialysis. You can see the thick epinuclear plate which is removed and aspirated in the anterior chamber. Now using the irrigation in the anterior chamber, limited pars plana vitrectomy is performed to prevent any further prolapse of the vitreous. The capsular tension ring is inserted to expand the bag and to provide more stability. In this case, we are using the bimanual method in which the forceps guides the leading part of the capsular tension ring directly into the area of the subluxation and the trailing part is threaded into the bag with the help of the dialer. The CTR is dialed into the bag such that the weak zone is adequately supported by the ring. A single piece foldable IOL is injected into the bag and trailing haptic is gently pushed under the anterior capsular margin so that the haptics are placed in the areas of the ZD. Now you can see the well-centered IOL in the back with round pupil. Trocars are removed. AC is formed with air bubble. We can see the pre-op eye with infratemporal zonulodialysis and cataract with best corrected visual acuity of 3/60. Also, the 6-month post-op eye with clear cornea, round pupil and well-centered IOL with best corrected visual acuity of 6/9. So, the take-home messages are: make sure we have the options for secondary IOL before the start of the surgery. Use high molecular weight cohesive viscoelastics. Capsular access should be initiated away from the area of zonulodialysis. Gentle hydrodissection should be done with no nuclear rotation. Phacoemulsification should be done with low parameters. CTR should be used to stabilize the bag. If vitreous is present in the AC, anterior vitrectomy should be done after staining with triamcinolone.
Though you said the Rexus should be started away from the dialysis, you started there only. And then almost 180 degree, nearing 180 degree of dialysis. So I think CTS must be a better choice, no?
4 to 5 clockers. Yes, ma'am.
Yeah.
Yes, ma'am.
Okay.
The only thing you'll have to look for decentration.
Yes, ma'am. That's why 6-month post-op, it was well centered.
Thank you.
Thank you, ma'am.
Dr. Jyoti Anup.
Yeah.
This was an unforgettable case for me as I had to struggle a lot. Patient had a well-dilated pupil, grade 1 soft cataract, started surgery as usual under topical. As soon as I started emulsification, pupil suddenly came down with all the classical signs of IFIS with the iris fluttering. As I took out the probe, iris prolapsed through the main wound. There was no documented history of treatment for BPH. When I had experienced all this, I asked the patient on table whether he had any prostatic complaint. He told me now he doesn't have any complaint since he had already undergone surgery for prostate 2 months back. I stopped the case, gave posterior subtenance on table since I expect some iris manipulations. So now the iris is being reposited. A dispersive viscoelastic is being used. You have to be really gentle in repositing the iris as there is a risk of hyphema as well as there is a risk of iridodialysis when you reposit back. When I saw the pupil is well dilated, I made one more attempt to proceed with phacoemulsification. Unfortunately, the pupil came down again, and it was a soft cataract. The only option left for me was to use pupillary expanders. So I am using iris hooks. These are iris hooks, not capsular hooks. This was also a challenge for me as there is a risk of inadvertent hooking of the rexus margin. This I managed by injecting viscoelastic. As you can see here, before each hook I am injecting viscoelastic between the iris and the anterior capsular margin. So I was successful in that step. Another additional headache was this was a very soft cataract, so the proper chopping could not be done, and you can see the nucleus became a ball, and I had to really struggle to remove this soft nucleus. removed the ball by tumbling. Another problem I faced was the position of hooks were not optimal. As you can see here, it had become a rectangle instead of a square. Actually, what happened was I had placed already I had done the side pot, and the iris hooks were inserted through though I had made separate pots here, these were intended for iris hooks, but I placed the iris hooks through my actual side pots. So the manipulation of my second instrument also became very difficult, and there was a large band of iris tissue which I had to inject viscoelastic every time to push it down before inserting instruments. Side pots were not optimal. I had difficulty in removing the epinucleus, and the subincisional cortex became a big struggle. So the subincisional epinucleus I could not remove. I'm removing this iris hook to use my side pot. This was the actual side pot. I placed my iris hooks through this. I could succeed in this step also. I could remove the subincisional cortex. IOL implantation was smooth. Finally, I could complete the case reasonably well. In every case of IFIS, at the end of the surgery, you have to hydrate the wound very well. Though I struggled a lot, I literally struggled in almost every step of the surgery. I could complete the case reasonably well.
Yes, you nicely managed the case. So, what lessons you learned from this?
No, a proper preoperative evaluation, that a simple history would have made, made the surgeon should have avoided lot of stress for the surgeon actually. So I think in the preoperative evaluation of cataract, most of the time the patient won't be knowing this history is important. So you have to a proper history is very important, especially in male, though it can be seen in females also, because it is given for urinary retention in the treatment of hypertension, at least in the OPD for a mid-dilated people, a male patient, this history is mandatory. And for this patient, this was the previous part was not recorded actually. It was a simple, straightforward, fully dilated people. I was literally surprised, and I really struggled a lot for this patient.
Did you try intracameral adrenaline since it was dilated earlier?
Yes.
It had dilated well,
Yes,
isn't
yes.
it? Adrenaline, intracameral?
No, usually for this patient I haven't tried because I knew it was an IFIS, so only some preoperative, if the pupil is small, I use intracameral adrenaline. Otherwise, straight away iris hooks. And if I knew, if we knew there is a history of BPH, I use the dispersive viscoelastic in advance, so there is not much of problem. But if you don't know, and once the IFI starts, then it is better. I always use iris hooks.
Also, never use sphincterotomies in these types of cases. Never.
No, we should not. It will aggravate the IFIs actually.
Yes. Okay, thank you.
Thank you.
So, this session is over. Thank you.